Ladies and gentlemen, Sure. Ladies and gentlemen, welcome. Welcome to the first OU JLIC Mental Health Awareness Panel, entitled Anxiety, Depression, Let's Talk About It. We have a very robust, multifaceted panel here with us tonight. Some very short words of introduction. My name is Rabbi Reuven Boshnak. I'm the OU's JLIC educator at Brooklyn College. My wife, to my left, is Shira Boshnak, the OU's JLIC educator at Brooklyn College. We've been here for the last 10 years, providing friendship, mentorship, education, Rebbe Mora for students in Brooklyn College. Over the past 10 years, we've had a snapshot really of what's going on. And we saw a tremendous need to help create shleimus, to create wholeness in physical and spiritual health. And as a result, that's one of the reasons this panel came together. We're calling it specifically mental health because everybody needs mental health. The truth is, our perspective is that each person is an olam maleh, it's an entire world. And the more they understand the interconnected shlavim, the interconnected levels of their lives, the meso, the macro, the micro levels, all the different levels, their interactions with themselves, with their families, with their society, the more healthy we can be in our interactions and understanding ourselves, the more shalem we'll become. It's in the book also, but I can't help but quote a teaching from Rav Kook, where he says that you have to know yourself, know your world, know everything that surrounds you. Because when you do, you'll realize that you have the wings of an eagle. And if you neglect those wings, you'll lose them. But if you search for them, you'll surely find them. So these are the first steps in awareness of mental health, in awareness of ourselves. And there's a really big schus for my wife and I to be able to convene this panel, to bring all of us together on a fantastic a fantastic journey, which comprises a huge amount of disciplines, from psychiatry, psychology, social work, rabbinics, haskanas, all these different facets, all these different components that make up our world. And we're taking these steps together. And we're really excited to share this panel with you. So, I guess without any further ado, I'll also introduce my co-moderator, Lauren Bahar, who will be co-moderating. And I can think of no better way to introduce the panel than to have the panel introduce themselves in their own words. So to open up our panel with a question is really, panelists, please introduce yourselves. Who are you? And in what situation would somebody reach out to you? What situation would somebody call you? We're going to ask the panelists to try to stick at maximum to 2 to 3 minutes, because like we said, it's a robust panel. There's a lot to say, a lot of ideas. But we also want to leave before Kriyat Shema tomorrow morning. So it's a big honor to begin. I think we'll just start on my right, and we'll play hot potato with a mic.
Good evening, Rabbi Yisrael Grossberg. I'm pretty sure I'm the only non-mental health professional on this panel, but yet as a Rav, we play... Don't get me started. As a Rav, though, in many ways we play a very big role in mental health. And really, I could say that it's divided into different areas that a Rav is often called upon. Firstly, it's a new world for many people. People need chizuk, people need direction, and oftentimes the first person that they're going to turn to is their Rav, someone who gives them spiritual guidance. There are people who are still not used to the entire concept of therapy. It's sometimes strange and foreign to them, and when they have the comfort that they're being sent in that direction by a Rav, someone who they trust, so in many ways that can be very helpful. In addition, as the rabbinic advisor to an organization that hopefully you'll find out about a little later on this evening, Chaskenu, which is an organization for women who are struggling with mental illness, who get together as a group. There's a whole host of programs that they have, but many times I'll be called upon for halachic shilas that really only someone with a knowledge of mental health can answer. For example, before Pesach I'll get many calls. The Seder is a very stressful time for me. What specifically do I need to be by the Seder for to be Makayim the mitzvahs of the Seder? Kibbut Avayim shilas that come up, kashrus shilas that come up. Music during Sfira, if music is the thing that calms someone down. Even the shilah that came up of someone having their music playing an entire yontif, if that's what gets. There are many halachic shilas that come in where I'm sure that many of the mental health professionals can answer these questions as well, but there's a certain feeling of comfort when it comes from a Rav, and there are times, many times, I'll be called upon where a therapist will say, I have a client, a consumer who I'm working with, and they need to hear from a Rav that what I'm asking them to do is okay. So that's something I can do. And finally, there are some areas, for example, in OCD or other places where, let's say, the issue is, just for example, in Netilas Yadayim, unfortunately, those that are constantly concerned that they've done Netilas Yadayim properly. So if their therapist or someone else, non-rabbinic person may tell them that it's okay, they don't have to continue, they may have a hard time accepting that. Again, when they hear from a Rav, and they hear from someone who they feel is knowledgeable in that area, they may be quicker to accept it, and in that sense, you offer comfort not only to the person who's getting the therapy, but to the entire family as well.
Hi, my name is Ronan Hazami, and I like to take long walks on the beach. Oops, sorry. So I'm a medical doctor. I'm a board certified child, adolescent, and adult psychiatrist. You might hear me if I just hold the microphone closer. So when I look back at all the years of my training, it kind of scares me. Because actually, this room scares me. Because I was here from 1988 to 1991, and when I came down here this evening, this room looks a lot smaller than it used to look. So after medical school, to be a psychiatrist, you have to do 4 years of residency. So that's the same number of years as an OBGYN. And then to be a child psychiatrist, you need to do another 2 years. So that takes me up to 6 years, which is in the magnitude of some surgeons and things like that. To put things into perspective a little bit, and to be brutally honest, the first lesson that they taught us on the first day of residency, after they gave us our IDs and our keys, was to tell us that 50% of what we're going to teach you in the next 4 years is going to be wrong in 10 years. The problem is that we don't know which half is going to be wrong. And I'd say the numbers are probably even a little conservative. So what does a psychiatrist do? The role of the psychiatrist has changed. Just to understand, there are about 8,000 doctors like me in the entire United States that see patients. There are states that have just one child psychiatrist. I think the Upper West Side of Manhattan and maybe the 5 towns in Great Neck are the only places that have enough for too many. The psychiatrist today, as I was trained, is mostly someone who does evaluations, who manages medications, who formulates treatment plans, who in theory is kind of running the case, although many times the gentleman sitting to my right is usually really running the case. We'll talk about it later. That's right. So most of the time, people don't just open up the phone book and decide today that they want to see a psychiatrist. Most of the time, they get referred either by their Rav or their primary care doctor or by a therapist. The times when people would come directly today, or by the school actually as well. When people would come directly today, is if someone's really not functioning, or if, if there's a real concern that someone's a risk to themselves, then the right thing to do is to skip straight to seeing a psychiatrist. And now I'm going to pass on the baton.
Thank you. If you spoke about me, I can speak about you. Just got to think of what to say. I'm Alexander Rand. Thank you. I'm a clinical social worker and an addictions counselor. So my background and training was initially in a drug and alcohol rehab and inpatient rehab for a couple of years, and then with the Jewish Board. I know there's representation of the Jewish Board here for about 7.5 years, and most recently in private practice, and I also teach in local schools. People call when there's a mental health issue, and the first phone call sometimes is very vague. People aren't clear about what it is that they're looking for, what they need. Do they need a therapist? Do they need a psychiatrist? Do they need a rabbi? So that's part of the process in walking people through the first phone call. And when appropriate, taking the case and working collaboratively with the other professionals that are involved, which is a very important piece. Mental health is not just one person who's going to, as Dr. Azami said, one person is going to do everything. Without collaboration, talking about the schools, the parents, the families, whatever's necessary, whatever's indicated, you have a much greater chance of helping the client when you're working together rather than working in isolation in a vacuum. I'm proud to be a part of the panel tonight. Thank you.
Hi, good evening. My name is Tzvi Gluck. Before I tell you about me, I just want to take a second and really thank Rabbi and Rebbetzin Boschnick for putting this together. And more importantly, thank everyone that came out here tonight to be here. One of the main areas that we try to target, that we try to deal with, is in breaking the stigma associated with people seeking help. One of the main areas that we try to target, that we try to deal with. And I'd love to hear Is it off?
Dr. Azami, was the echo so bad when you were in school also?
Are we good? Wow, okay. Anyway, we try to break the stigma associated with mental health. I founded an organization 3 years ago called Amudim Community Resources. Initially started to be a crisis response and intervention organization, primarily focused on victims of sexual abuse and those suffering from addiction. And we quickly added in the awareness component, realizing that it's great that we try to help people after the fact. It would be better if we could put ourselves out of business for every reason other than lack of funding. That being said, part of what we try to do is work with the treatment professionals, treatment programs, mental health world, rabbinical leadership, and many others in making sure that the glue that has to maintain the treatment and the necessary care remains together on a multifaceted approach with a 30,000-foot view, making sure that not only the client gets the services that they need, but the family members and other affected individuals do as well. In order for us to succeed in what we're doing and look for the true follow-up, it really requires events such as this and making people aware, putting people, out there and really just saying, this is what we're dealing with, this is what the world is. I've said this a few times, I'll say it again. Many, many years ago, people were scared to talk about when they had children that were born with developmental disabilities, and often putting them in homes where they would live for many, many years not being with their family. That stigma was broken. There was the stigma of people battling cancer, where they couldn't even say the word or let people know that a loved one was sick. Then there was the issue with dealing with the term that I hate of at-risk youth, because I think we're all at risk, and that broke. And the time has now come to be able to look, whether it's mental illness, victims of abuse, or other things in the face and say, we're not going to let this get to us, and we're going to do what we can to help those. Thank you all for coming, and thank you again to the Boschnicks putting it together.
Hi, my name is Dr. Pearlstein. I'm a clinical psychologist. I completed my training at Hofstra University, and I did some training with Salvador Minuchin in structural family therapy, with Aaron Beck, who developed CBT that we're going to talk a little bit more about later, and also intensive training through BTEC in dialectical behavior therapy. Most people call me, either it's kind of, there's a divide, either they're in crisis, and something happened recently that they need to seek a mental health professional. They're not really sure. Very often they're ambivalent about it, and the call itself doesn't necessarily mean that they're going to seek treatment, but it definitely is the first step. And also, there are some people who don't understand or can differentiate between anxiety and worry. We all worry, but when does it impact your daily functioning or your quality of life? Or sadness versus depression, and that's what we're going to talk a little bit more about.
My name is Judith Leventhal. I'm a licensed social worker, and initially I trained as a Gestalt therapist. And I thought for sure I'd have my life tracked out for me, I'm going to be a therapist, and that's it. But God had a different plan, and through a series of incredible coincidences, I became the co-author of the Small Miracle series. And over the course of the past 18 years, my co-author and I, Yitzhak Halberstam, have written 8 books about coincidences, and like you have many of them, thank you. Alongside the writing of the book, I continue to train as a therapist, and most recently I've trained as a somatic experiencing. And somatic experiencing, in a nutshell, is basically feelings and anxiety, depression, anxiety, these feelings are often stored in our body and unconsciously. And somatic experiencing helps a client touch those feelings that are stored, and that in bringing awareness to it, that's part of the recovery process. So right now I'm in private practice, and I work particularly with people in, struggling with anxiety and depression and these kind of illnesses, and so I'm glad to be here, glad to be part of this panel. Thank you.
Okay, before we move on to the second question, we also want to mention that the booklet in the night is Leila Nishmas Rivka Esther Bas David Yosef and Shama Shnaf and Aliyah.
All right, well, thank you all for your introductions. So, as individuals, we have friends, and sometimes friends come to us with questions. And how do you know when something is too big for like me, for instance, to help a friend out? So this question is directed to people.
Perfect question for me. Is there such a thing? No, I'm joking. So one of the things that we notice a lot is friends really care about each other and want to get each other the best help possible. Now, I know that I was given a special type of smicha tonight as a mental health professional, but I will readdress that and say I am not. So I'm clearly speaking as a layperson, not as a mental health professional. But friends need to also realize that when something is a little bit more than they can chew, they need to be able to feel comfortable and take it up a level, whether it's to a mental health professional, whether it's to a guidance counselor in a school, whether someone in administration. Many times we have friends, people that come to us for help, that for many, many months were being guided by their best friend, and while it was done very well-intentioned, very important care that should have been initiated was not able to be done. So while it's important that friends are there, and friends should be there for those that are suffering and need it, it's just as important for a friend to know to be there to support that person, to get the proper therapy, or to seek the proper help and not try to solve the problems on their own.
Okay, dovetailing into the next question. Let's say you have 4 things, you have 4 sentences, 4 facts that you can tell this entire room, all the people out there in Facebook Live land, wherever this recording is going to go. If we made it into a meme, maybe with your face pointing out that way. What 4 things would you want to tell somebody who's facing an addiction, somebody whose friend is facing an addiction, or somebody whose family member is facing an addiction? So, Alex Rand and Speak Love, those 4 things, what would those 4 things be? Please let us know.
So it's hard to encompass, what I want people to know in 4 things, but we're going to try. The first thing that I found is that, especially I worked with young adults, teenagers, and adults. I don't work with children, but with young adults, nobody decides one night when they go to sleep, I'm going to wake up tomorrow and be an addict. It's not planned. Every single person that uses says, I'm going to do this recreationally, once, twice. And the problem is you don't know at what point you're going to cross that line, what your body chemistry is, what your predisposition is to it that can lead to addiction. So it's not something that people are ready for, plan out, or decide they want to become. It happens over time, and it happens slowly and gradually. The second thing that I would mention is that the disease model, right? I think in the 1930s, I believe, the AMA recognized alcoholism as a disease, and addiction as a disease. It's a DSM diagnosis. Yet there still seems to be a number of people, and maybe our own feelings towards it. We get angry at people for using drugs. We don't get angry at people for other diseases, right? You don't get angry at somebody for having cancer, but people do get angry at someone for using. They feel that they're choosing it. And to some degree, yes, there's choice and responsibility involved, but to some degree there's also this aspect of disease, which is out of their control and they need help. A third thing I would mention is that there's no one word of addiction. People use on different levels and abuse on different levels. Not everybody needs the same level of treatment. Treatment can go from once a week in outpatient therapy all the way to inpatient in a hospital and a rehab, and everything in between. So you can't just make an assumption of somebody's using, they need this or they need that. There needs to be an assessment done, and based on where they're at and the problems that they're facing, the right level of treatment needs to be recommended. And lastly, I just want to mention that, because this is a hot topic now, with marijuana becoming practically legal across the United States, you know, every kid I encounter is like, it's legal, it's okay, it's a plant. Okay, first of all, it's a plant, so is cocaine. It comes from a plant as well. And there's like 3,000 plants in Africa that will kill you if you eat them. So this idea that it's natural, it's okay, and we see kids' lives that get destroyed through marijuana use. Even if they're legalizing it specifically for adults, first of all, and for specific issues. Yes, there is some legalization at this point for recreation as well, but for brains that are not fully developed, adolescents, young adults, the risks are far greater in terms of being a gateway drug or in terms of people that only use marijuana yet wreck their entire lives.
Oh, so you took all my answers, but if I were to just mimic some of what you said and then take it another step, I'm going to just reiterate, addiction is a disease. People do not choose to be addicts. Addicts are good people that need help. They're not bad people, they're not evil people. We need to give addicts the love and compassion that they need as we would anybody with any other ailment. And also to understand at the same time that and I'm again copying it for a reason, but nobody chooses to be an addict. But that being said, we also have to remember, and we get into this trouble a lot, you're not alone. If somebody is suffering from addiction, there are many people out there. Seek help. There is help available, and there's also help available for the people that live with the addict. So it's not just about the addict themselves getting help. It's important to know that the other affected people need help as well. I have people calling me up saying, you know, my husband's drinking too much and just get him the help he needs. And when I ask the wife, well, are you also willing to go to meetings and to be involved and to participate? Oh no, he's the problem, not me. Now, while that may or may not be true, but to solve that problem, we need everybody involved. And we also have to remember addiction isn't only just drugs or alcohol. We are seeing a tremendous increase within our community in gambling, porn addiction, sex addiction, and so many other things that we need to keep that all in mind. These are people that are sick, and just like someone who has any other disease, we need to do the same for anyone who's suffering from an addiction.
I just wanted to add something, if I may. I wanted to add something very, very important. I have, fortunately or unfortunately, had the privilege of working with several very upstanding members of our community. People in their 40s, 50s, even 60s. The people that put on the parlor meetings in their homes for various yeshivas and organizations, who throughout their lives never thought of using anything illicit. And then they needed back surgery, or they needed some procedure done, and an irresponsible, well-meaning physician gave them way too much medication for their pain. and didn't monitor them properly. And these people lost everything. They ended up divorced, losing their families, losing everything. Al ta'amin ba'atzmecha ad yom motcha applies very, very much to addictions. There's a genetic predisposition to this. And we all need to watch ourselves, not just young people. This is a real thing that can really happen to anyone.
Thank you. Before we continue, I just want to make sure everyone's comfortable. There are a few more seats in the front here. I know it may be a little bit difficult to get through, but there are 2 aisles here, so please feel free to move up, find a seat. Yeah. Seven one eight 831-6903. That's the number. Okay, so if you have that number, you can text in first OU, JLIC, MHA. So that's if you have a question, you can text it to that, and it's anonymous. You'll get a response, and that's just another way of having your questions answered. Okay.
Lauren, if you're on Facebook Live, for our people that are watching live, you can also put your questions there. We're monitoring it, and they can answer there too.
Okay, and those questions will be addressed after we finish the list of questions. Next 3 weeks, right? Yes.
There are also some sheets on some of the chairs here regarding the texting. But I'm going to continue going. Okay, so the next question I'm going to direct to Dr. Perlstein, if you can pass this down to her. So it's pretty similar to the one we just answered. It's if you can say 4 things about somebody, about suicide, whether it's suicide ideation or somebody who's maybe planning suicide, whether it's the person or a friend, what could you say about suicide in general for? So we're going to direct the question to Dr. Perlstein, and then Zviglok, and then to Alexander Brad.
Okay.
Thank you.
Okay. So it's a great question. The most important thing I would want to tell you is that you need to learn the science, because a family member of someone who recently committed suicide confided in me that this person's, I'm sorry? Louder? Okay, closer to me now. Okay, do you hear me now?
Yeah.
Okay, so a family member of someone who recently committed suicide told me that this person's therapist said, as long as this woman is talking about it, then she's not going to commit suicide. That is absolutely contraindicated in the literature. If you look at the risk factors, and risk factors aren't causal, it doesn't mean that you're going to commit suicide, but it does increase the likelihood that you will, is that current suicidal ideation is a risk factor. A plan, if you are talking about a plan, if you're writing a suicide note, that's a risk factor. And past attempt is also very scary, that's first of all. Second of all, the leading cause of suicide is major depressive disorder, and the leading symptom of depression is hopelessness. So I would tell you that if anybody is talking about suicide, if they're expressing a suicidal ideation, if it's somebody that you know, then you need to instill hope in this person, because suicide is a hope effect, okay? That's second of all. Third, it's not enough to be passive about it. In other words, you need to be active about it. You have to make sure that this person is actually seeking help, and you have to follow up. So this is something where you don't have to worry about enabling somebody, right? And if you think that it's attention seeking, that's not your call. I would say that as well. And fourth, and this is very, very important, the scariest time is when somebody starts receiving treatment, especially medication, because it takes a couple weeks to kick in. And it's very possible that they're going to experience a surge in energy, because one of the things that we're going to talk about is that depression depletes you of your energy. So they're getting more energy, but the suicidal ideation is still there. So they have energy to go ahead and carry out the act, but they don't have any hope, so they're going to go ahead and do it.
So, speaking about suicide is something really tough because in the past I've actually gotten into trouble about it, which is okay because I'm not really a stranger to controversy. But when someone has feelings of it or says something, take them seriously. All too often we've had people call us up and say, my friend is threatening A, B, C, and D or is acting in this way, but she or he will be upset if I call an ambulance or if I get them to a hospital, and I don't want to upset them. So my answer to that is, a living friend is better than a dead one. And don't take the chance, don't try to be the hero and try to figure it out on your own. But get someone the help that they actually need. Don't overreact, don't go insane about it, but be willing to get them help. There's also something else that I have to touch on. There are people that get diagnosed with cancer and they go through the best form of treatment, and yet they still pass away. And that's a sad reality of a disease. And I have, all too often, when people have taken their own lives, their friends and loved ones end up getting very depressed about it, wondering what more they could have done, and then they feel guilty, and then they end up going into their own downward spiral over it. So we also need to understand the reality that these things sadly do happen, and we can't take it personal. Yes, we have to do our part to save anyone that can be saved, but we cannot take it personal and eat ourselves up about it. We just need to be able to help those that need it and get those the help that they desperately need. And if we see the signs, especially on the friend level, try to get them help. Reach out, do what you have to do. Don't just try to deal with it yourself.
Okay. A number of the points were made, so I'm just going to stick to one or two. There's a myth that by talking about suicide, you increase the risk. And in fact, the research shows the opposite, that by discussing it, you actually decrease the risk. There are schools that are like hesitant about addressing things like self-harm because we're going to give kids ideas, but we find that that's not true. It's a touchy subject, and sometimes even therapists, let alone family members, are afraid to almost ask a client directly. And you need to ask somebody directly. Are you thinking of hurting yourself? Are you thinking of killing yourself? The questions need to be very clear, not vague, not stepping back, but direct. Another point I want to make is that, sometimes when it comes to mental illness, it's easy for us to look at somebody else and really not connect and understand what they're going through, and just see it as odd or strange or not normal. People that are suicidal, that have suicidal thoughts, are in immense pain. More pain than most people here have experienced. And if you can't connect to that pain and realize that this is not, a ploy for help or for attention and a way for people to notice them, that people are truly suffering to the point where if somebody's thinking about killing themselves, they've decided that there's less pain in not existing than there is in staying in the world. That there's no hope. And this is true for people that are young, as young adolescents, all the way through, late adulthood.
So when it comes to suicide, we don't always have the answers. I remember the first patient that I lost many years ago in my private practice. And after 120, to this day, there are lots of things in my life that didn't go the way that I wanted. But I don't think that I'm going to go up asking God why. I think I'm going to ask about this patient. We don't always have the answers. It doesn't always make sense. Sometimes people are horribly depressed, and you can kind of see the progression when you look back. But sometimes people are really not in their right mind. They're completely confused. They're intoxicated. They have a medical condition, and they're not able to think clearly. And they end up doing something that ends up hurting them, and there's no way for us to know whether they intentionally meant to take their lives or not. Okay? So be careful not to overthink this. The other key point is when you hear us talking about asking the question clearly, that's for us to do. Okay? A family member doesn't necessarily have the tools to know what to do with that question. If you have a concern, it's like, Chafetz Chashut, which has now come to the United States. If you see something, say something. The same thing applies here. If you're really concerned, say something to someone that can do something about it. Talk to the family rabbi, talk to your pediatrician, talk to your primary care doctor, If there's a mental health professional involved, get to them immediately. If you have a legitimate concern and there isn't a mental health professional involved, get to one quickly. And if you can't get to one quickly, that's why the emergency room is there. Sorry.
I just feel the need to add this. I've been working in this field for approximately the last 7 or 8 years. 10 years ago, if I'd be sitting where you're sitting, I probably would think I've come to the wrong place right now. Because I came to hear about depression, anxiety, you know, my kids taking finals and they're having a very tough time, and there's anxiety, etc. Unfortunately, in the last 7 years, I've buried Talmidim and Talmidos. It's very real. And just because you may not know about it, it could be your neighbor, it could be your child, it could be anyone who's close to you. The things that we're discussing here, although they may seem extreme, and although you personally may think that it's not touching you at all, in our community, this is very real. Every single person on this panel, I am sure, is getting calls literally day and night, as recently as last night, 2:30 in the morning, day and night, of people who outwardly seem fine, who really seem okay, etc., and they're finally opening up, and so on. So again, this is not to, you know, gloom and doom and all the other issues, but we're talking about people, you know, as they say, from the best in the Shensta, from the, you know, the best families. Everything seems to have everything going for them. This is not an isolated issue, and I bring it up again because I would have thought it was before, because it's not spoken about. You know, unfortunately, the buzzword is aneurysm, because you don't want to go around saying that what really happened. So when there's a cause that you don't want to say exactly what happened, that's the word that's used. But it's very real, and it's really something that if every single person here walks out with that awareness, and walks out with that idea of seeing and feeling and being there for other people, that alone we've accomplished a major amount tonight.
Okay, so oftentimes people conflate the words psychiatrist and psychologist. Oftentimes people mix them up, they don't know which either one does. I actually once trained at NYU, and it was a program for the psychiatry program, and every time one of my clients would come in, the phone would ring and the receptionist would say, "Dr. Boshnak, your patient is here." Now, I'm a licensed mental health counselor. I have neither a PhD nor an MD. And they kept doing it, and I kept trying to correct them, and it just didn't work. So the next time I said, "Can you do me a favor, please, and call my mother?" So, I'd like to ask the two doctors on the panel, within your specialties, we have both talk therapy, we have medicine. In which circumstances would we only use medicine? Which circumstances would we only use talk therapy? Which situations would we use a combined approach? I guess we'll start with Dr. Izami, then move on to Dr. Krause. Okay, go for it.
So I'm going to tell you a little secret. Okay, you can tell other people about it. Within the entire field of medicine, not just mental health, with very few exceptions, medicines don't fix anything. When a person has an infection and they take an antibiotic and it does what it's supposed to do, it kills the bacteria. But if someone has a heart condition and they take heart medicine, hopefully it'll help them. And if they do nothing else, when they stop taking the medication, what happens? The heart problem comes right back. You have hypertension, high blood pressure. You take your antihypertensive. It's great. Your blood pressure comes down. You stop taking it. If you didn't exercise, lose weight, stop salt, all the other things that are in style for that week, you stop the medicine, the problem comes right back. That doesn't mean medication isn't effective. So to break it down simply, at the end of the day, what's the difference between medication and talk therapy? Well, the effects of medication will sometimes linger a little bit after you take them. It varies from medication to medication. Some medications leave the system within a few hours. Their effects can linger for sometimes a few weeks. But when a person goes for talk therapy, when they go for the right type of therapy for their condition, and they stick with it, and they have hatzlacha, hopefully some real changes have been made. And there's been plenty of research throughout the years that has shown very clearly that when you do these fancy scans that look at the metabolism in different parts of the brain, and you look and see what does medication do and what does therapy do, lots of times you end up with the same changes. Therapy takes longer, but if it's done properly, the effects linger. So for example, if we have someone with OCD, the data is very, very clear. There's a type of therapy called cognitive behavior therapy. This type of therapy doesn't fix the problem. It doesn't, the psychologist or the social worker or the licensed mental health counselor doesn't kind of, crack the brain open and dig deep down and disconnect some of the wires and reconnect them and tape their head back up. But what they're doing is they're giving the person the tools to handle their problem more effectively. Now, medication will get them to feeling just as good many times, a little bit faster, and when you combine the two, you get an even better, robust response. But at the end of the day, if someone comes into my office with OCD, in most cases, unless they're really, really not functioning, they're going to get a referral to a therapist to get what's called cognitive behavior therapy. Now, I really, really like ketchup, but not on my ice cream. Okay? So when we talk about when medication is effective, when we talk about when therapy is effective, we need to talk about what's the diagnosis, what type of medication, what type of therapy are we talking about. And we also need to be really, really honest with ourselves about the role of research and the role of statistics. How many people here have kids? Kanainahara, very good. How many people in this room have an equal number of boys and girls? Okay, how many have an unequal number? So I have 4 boys and 1 girl. Does that mean that the statistics are wrong, 50-50? No, because statistics are meaningless when applied to an individual. If there's a type of cancer that has a 95% survival rate, that doesn't help the person that was just buried that was in the other 10%. So just because there's research that shows that something is very effective, it doesn't predict that it's going to be effective for that individual. And then it becomes our job to assess the person, to see how they're doing, to see what's the right intervention for them, whether to continue it or not. So this isn't really the right forum, because I could be up here for 3 hours and put all of you to sleep talking about the different medications, the different conditions, but just understand that there are some conditions that the research is very, very clear, that if you're not giving medication, you're essentially wasting your time. You can do all the therapy you want in the world, you're wasting your time. And there are those conditions that even medication doesn't help. Okay, and there are those conditions that are better served with psychotherapy, that psychotherapy is more effective or equally effective and certainly has less side effects. Okay, so this is part of why we have so much training and why experience is so necessary. There are lots of people out in the community that say, hey, I'm a smart guy, I can read the same books that you read. And I can tell someone what to do. I get this in my office all the time. People come in, they're bringing the patient in and asking from the community, very, very well-meaning. And I look at them and I say, I'm a frum guy, I know how to learn. How would you feel if I paskin halacha? Shimush is huge, and that's one of the hugest, most important parts of going to a training program, is that supervision that teaches us how to make these determinations, how to decide when chocolate syrup's the right thing, when ketchup's the right thing, and how to figure it out.
Yeah, okay, so just a couple of things, because I think Dr. Zami covered it all. No, that's great. Right, 6 years of medical school plus the 4 years in the residency. Okay, so just a couple of things that just to sort of tag on to what Dr. Hazami was saying. Today, most clinicians and diagnosticians would agree that most forms of psychopathology is due to the biopsychosocial model. In other words, there's something going on biologically, there's something going on psychologically, and socially. So the idea is that there are exceptions, that there are some conditions, as Dr. Hazami pointed out, that medication is absolutely necessary and that cognitive behavior therapy will be ineffective. So for instance, ADHD, the research is pretty clear on that. But there are some conditions, like many of the anxiety-based disorders, that if you are taking medication and you're not in active treatment, in other words, you're not, for OCD, for instance, we do a lot of exposure and response prevention, which we can talk about a little bit later, then you're not going to see treatment gains. So it's intellectually dishonest to go to a psychiatrist and assume that you might experience symptoms reduction, but your quality of life is not necessarily going to get better. The goal of therapy is to develop skills. It's skill-based. And the idea is that can you apply those skills in everyday life? So that even if you are experiencing less symptoms of depression, are you happier? And even if you're experiencing, even if, let's say, for instance, anxiety, you're not experiencing the physiological symptoms. So the medication is taking care of, for instance, your increased heart rate or your hyperventilation, right? But the idea is, what are you doing when you're approached by a situation that's activating your anxiety? What are you doing about that? So the goal of therapy is to provide the client with the skills that are necessary to improve their quality of life. So it's symptoms reduction and it's quality of life. So we need both, generally.
Okay, so a lot of times we misuse words, So, people say they're depressed, they're sad, they're worried, they're anxious. So what I'd like to ask the panel is, how do you know what's the difference between sadness or depression or anxiety and being just general fear? So this question is directed to, pass all the way down to Judith Leventhal, or at number 13.
I'll stand up here. Thanks. So there's a quote, sadness is a human feeling, not one that is enjoyable necessarily. Depression is a whole other thing. Depression is where you feel nothing. Depression is where you just don't want to live another day. That's a quote. It's a quote from a book written by J.K. Rowling, the author of the Harry Potter series. She's written a book on depression. Her own depression, which really shows that depression does not discriminate. Depression hits people that are successful as well as non-successful. Poor, rich, it does not discriminate. Now let's talk about what's the differences between sadness and depression. Sadness, like J.K. Rowling said, is just a human emotion. In the spectrum of feelings, there are so many. There's joy, excitement, anger. Sadness is just another one of those. Sadness comes and goes. It processes through and it moves on. Depression, however, is a whole other animal. Depression has been called like the dark night of the soul. Depression is when you wake up in the morning and you discover that there's an elephant's foot on your chest. Every single day, we are all faced with different kind of challenges. Some mild, some greater challenges, and sometimes a little difficult to get through the day. It could be challenging. But with depression, it makes it almost impossible to get through the day because you're so busy fighting that elephant's foot. Between sadness and depression, another thing to say about that is that sadness could be prompted by some internal or external experience, whereas depression isn't necessarily prompted by anything. So for example, like in depression, there's internal and there's external prompters, right? So external could be something like losing some money or getting fired from a job. That could be something that contributes to mild depression. And then there's moderate and extreme depression, you know? So those could be like, I grew up with parents that were Holocaust survivors. All my friends were children of Holocaust survivors. So I really saw depression up close because so many survivors lived and breathed that dark night of the soul. So I saw it up front, I saw it up close. When someone is in depression, it's like living in a fog within a cage that has no key. But that's just a metaphor, and that's just an illusion. The truth is, there is a key. And I think tonight provides so many of those keys. Whether it's going to a doctor, seeking out advice from a therapist, no one living with depression has to live in that cage with no key, because there are so many. That's it.
Thank you for that. Thank you for that great imagery. Dr. Pearlstein?
Yeah, I just a little bit, if that's okay. One of the things that you have to look at if you want to differentiate between sadness and depression or worry and anxiety is that you have to look at the frequency of how often you're experiencing worry, the intensity. In other words, is it worry or is it panic or anxiety? And then the other thing we look at is duration. Because depression, a major depressive episode is 2 weeks. So if you're waking up 2 weeks, the way that Judith explained, where you just don't want to get out of bed and you socially withdraw and you're just feeling very, very sad. And you have no interest in doing anything that typically would cause you pleasure. But if it's going on for 2 weeks, then you are experiencing a major depressive episode. And you need to take action. You need to seek out a mental health professional. With anxiety, it works the same way. If it's affecting your ability to function, and you're experiencing symptoms, either it's physically, so you're experiencing, the heart palpitation, the butterflies in the stomach, all that. We call it sympathetic response, arousal, or the constant rumination. We call it ruminating, where you think about something over and over and over again, and it's you can't distract from it. And the behavior component of anxiety is avoidance, because we avoid things that we're anxious about. Then you're dealing with anxiety. It's not real life worry. So again, you look at frequency, how often you're experiencing it, how intensely are these symptoms, and the duration. Can you bring yourself back to that comfortable baseline of emotion?
I just wanted to add a couple of points. To reiterate, many times what helps us decide whether something is on the more serious side or not is an impairment in functioning. One of the most common lines I hear from patients is, "But doc, of course I'm going to be depressed. Don't you know that this just happened in my life?" And I say to them, "And if you fall and break your arm, how would you feel if I told you, of course you're in horrible pain and you can't sleep. Your arm's broken." Just because someone is having a bad reaction or is having an appropriate reaction to something doesn't mean that they shouldn't get help. If they lost someone, if they lost their job, if they're having marital issues and they're having symptoms, just because there's a good reason for those symptoms doesn't mean that we don't call it something, and doesn't mean that we don't take care of it.
Okay, moving back towards this side of the panel. We're going to be moving towards question 23. 23. Okay, so moving down towards this end of the table, there's an interesting question that my wife oftentimes will bring home a statement from somebody, or one of our students who's in social work school will call me with a question and say, well, the patient's rabbi said that if you really had emunah, you wouldn't be depressed or you wouldn't be anxious. So the problem is that really you just don't have emunah. So the question I'd like to address, starting with Rabbi Grossberg, right after Dr. Izami, you also, and Truth Leventhal, all have an answer for. Okay. Well, if we all have stuff to add, it's a free panel. So we'll start on the left and move down, and after Truth, anyone who wants to step in also, please feel free.
Okay. I was thinking one of the things that I thought about after I introduced myself is that as in my position, I think it's also important, besides saying what I do, it's important sometimes for Amudim to also know what we don't do. And the reason that is because with the best of intentions, I don't say that with any sarcasm whatsoever, many Rabbanim might tell someone, work on your emunah, when in reality they desperately need therapy and help. Simply because it doesn't come from a bad place. It just comes from that, for many years that's what we were told, and that's, if anything, this question is a dangerous question. I don't blame the guy who asked it, but because what it does, it adds guilt on top of everything else. So not only am I depressed, not only do I feel like things are going wrong in my life, but on top of everything else, I don't have good emunah. So I'm not a good Jew. So let's, going for the, all the problems. It's important for people to realize that, and this is something that's come up, from the esteemed panel many times over. No one ever looked at someone with any other ailment, machla, cancer, any other issue, and said, well, obviously they lack emunah, otherwise they wouldn't have that. Because clearly, this is something that no one chooses. No one says, I don't believe in Hashem, so I'm going to get depressed. Or if it would be as simple as sitting down and learning a Mussar Sefer, so the farm stores would be doing great, and everyone here would go out of business. Unfortunately, it's not that simple. And that's really where Rabbanim, mental health professionals who have a knowledge and understanding of where someone is coming from, really come in and can do it. Because that's, again, when choosing a therapist, it's not a topic that's come up, it's so important that you're choosing someone for yourself or for your child that understands the world that you're coming from. Because this is a whole separate issue, again, the emunah. So to answer the question, obviously, it doesn't represent in any way whatsoever a lack of emunah. Sometimes it's a chemical reaction that clearly has nothing to do with emunah. Sometimes it's just that as a human being with emotions, there are things that get us down that sometimes start to spiral and get out of hand, etc. But emunah and bitachon can sometimes help play a role as part of everything when done in a healthy way. But clearly, to just put it as a lack of emunah or pushing that emunah will change the thing is not only not correct, but also very dangerous.
So the head is not this empty box with spirits swirling around inside of it. The brain, the central nervous system, is no less physical. Now, very, very interesting thing happened to me. I had the privilege of treating some of the guys that responded to the September 11th attacks. And some of them were quite traumatized, some of them had other issues. They didn't all react the same way. Interesting. There's this new area in medicine called pharmacogenomics. I don't know if people have heard this. But, what it does is it looks at our genetic profiles, looks at what we have predispositions to, looks at the system in the liver that metabolizes medicine, and helps us understand what might be better choice of medication versus others. And in this type of testing, there's something fascinating. There is a gene for a serotonin receptor. Serotonin is one of the brain chemicals that are affected typically in depression and anxiety. So there's this receptor for serotonin in the brain called SLC6A4. There's going to be a test on this at the end. So whoever wasn't anxious already, you can start getting anxious.
And that will help you deal with it.
So there are two possible different genes for this. People that have two of the bad copies of the gene, there are lots of things that we can say about them. Number one, they're less likely to have positive responses and to tolerate SSRIs, which are medicines like Prozac and Zoloft. But people that have two bad copies of the gene are more likely to have long-lasting effects from childhood trauma. They're also more likely to develop post-traumatic stress disorder if they have a traumatic event as an adult. What that could possibly have to do with emunah is beyond me. Okay? We are all born, God created us all differently. We have different predispositions. We all have things we have to work on. We all, each single one of us, have the capability to reach our own level of Moshe Rabbeinu. The point of emunah has nothing to do when it comes to mental illness. When it comes to working on character defects, that maybe I'm a little bit too jealous or a little bit too stingy or I get angry too easily, that has nothing to do with mental illness. And we have to be very, very careful in making that distinction. As Jews, especially the mothers, we have more than enough guilt. We don't need more.
I think I'm especially qualified, being the most religious person on this panel, sorry for to answer this question. It's really disturbing hearing everyone else talk. And I can tell you that for regular people like you guys, you don't have to worry, it's not emunah b'tachon. For me, I can work through it with my emunah. I want to mention one case. I treated somebody who came in for OCD. We're talking about OCD. He was an extremely religious, conscientious young man. And of course, where does OCD hit? He would have inappropriate thoughts during davening. Really inappropriate thoughts during davening. And it drove him crazy. The guilt, the shame, like right when he was trying to daven and have kavanah, these images would pop into his head. Now we know that the premier treatment for OCD is CBT, exposure and response prevention, which is they have to purposefully expose the person that which they're avoiding. So imagine I'm telling him, I was a guy for a good few months, telling him you need to actually purposely bring up these thoughts into your head, not try to avoid them during davening, and sit with them. So of course, I couldn't do this alone. And I called a Rav, I called actually Reisman, Yisrael Reisman, with my client on the phone, because my client, of course, I was the Yetzer Hara. I said, Rabbi Reisman, I need you to tell my client what the halacha is. So you need to work together with a Rav sometimes, not just discount and say, listen, forget halacha, forget hashkafa, I'm a mental health practitioner, I know what you need to do. People obviously are from Jews, they respect halacha, they respect hashkafa. Many times it's important to work together with the Rav, usually the client's Rav, the Rav that the client feels comfortable with. And hopefully in that combination we can help people.
I want to go before you because you're probably going to reiterate what everyone else said, and I'm going to reiterate it, so just one bit less reiteration here. We all know someone who had, unfortunately, a diagnosis with some kind of illness, right? And what happens when you have that, when we get such a diagnosis? Do you say to the person, come on, you could take care of it, you could do this? Of course not. We spring into action. You call up, get the best referrals for the best doctor, you make appointments, you do what has to be done because the person has an illness. What happens when a person is diagnosed with depression? That's when the people say things like, come on, you could do this. If only you davened a little bit harder. If only you tried a little bit more, you could lick this thing. Come on, you know that. It's not true. Depression is an illness and has nothing to do with having emunah or not having emunah. I have a client that came in for sessions. The first session, she could not get her head off the side of the couch. She just laid it down because she was so depressed. This girl davened shachris, mincha, marev. Sometimes she texted me that she just davened nishmas 12 o'clock at night. She's got more emunah than anyone I ever met. But she couldn't get her head off the couch because she was that depressed. After a couple of months of therapy sessions and medicine, which she went on immediately, all of a sudden now, she's an upright citizen. She could function, she could work, she could smile. She's living life. She had emunah before. She has even more emunah now. Because she realized that some things are not in our control. We would love to believe that depression is completely in our control. I just have to think more better thoughts. I just have to go and exercise, and then it'll all be okay. We all wish that that was the case, but it's not. Some things we are totally powerless over, and illness is one of them. And depression is nothing less than an illness. So if there's one thing I think that we could take, if there's one message, because one of the questions is there's one message you want to take out of the night. And the one message is to take the stigma away from the illness, which would allow people who are struggling with this mental illness to step forward and take the actions that it requires to get free from this disease. Thanks.
I just want to make 2 points. First of all, I don't want to offend anybody here, but I think that some people, they confuse emunah for denial. So if you tell yourself, oh, I'm just going to have enough, emunah and bitachon and things will get better, and you're just waiting for that to happen, then you're not taking responsibility and you have to be active about that. Or on behalf of other people. The second point is that one of the things that I help clients that are struggling with anxiety is frame their avoidance as adaptive. And what I mean by that is that very often you feel guilty because you're avoiding something. So for instance, I once had a client who was in a car accident and she avoided getting into that car because she was afraid of getting into another accident, and she had intrusive thoughts about it, that she had these flashbacks of remembering what it was like, and she was berating herself because she said, if I had more emunah, I wouldn't avoid the car. I would just trust that Hashem will take care of me. And I pointed out that avoidance is adaptive. If she avoids that car, then she increases the likelihood of being safe. So that's why we avoid. Now, obviously, it's not helping her because she's not able to get into that car anymore. But what she considered lack of emunah was the opposite. So for my clients, what I work on is trying to reframe their conceptions or misconceptions.
So, maybe the last one on this question, but I'm not sure how your client can have emunah if she was texting. Now, obviously, that's a joke. But the concept is that the world today that we're living in, and the angle that and I hate to say this, but I will, that our leadership is taking, is they're misconstruing what's important in life, and where they're putting religion and emphasis on things in a way that's giving an already anxious or depressed or anyone suffering from mental illness more issues instead of helping them get better. So I'm going to say this very simply. Doctors treat medical issues. Rabbis can paskin shilas and help in things that are good for rabbis. And everyone has to know their place. This doesn't mean that there aren't rabbanim that are trained in other areas. It doesn't mean that there aren't people that can answer or know how to guide people in certain ways. But people have to know where they stand. We had someone come to us who was suffering from severe depression based on a very serious sex addiction. And they came to us for help to get them into a specific yeshiva that teaches Musar, because that's what their Rav told them will cure them. And when we reached out to that Rav and tried to use it as a teachable moment to get that Rav to understand what they were talking to, we were told we're apikarsim because we don't understand it. So really, I guess, okay, I'll take that as a compliment for the night. But what we really need to do is be able to address this in a way where we can educate, whether it's the Rabbanim or the leadership in the communities, to make them more aware of what mental illness really is, the treatments available, and how to separate their perception of the frumkeit as opposed to the reality of what's needed to help people really get over those hurdles.
By the way, this is on Facebook too, so talking about being from, anyway.
Thank you. So, as we mentioned tonight, there's a lot of reasons why a person would seek help, whether it's for an actual mental illness or, in my opinion, I believe, just if someone's really struggling, they may seek help. And get therapy. So I would like to ask, what should one expect when they go to therapy? Because, you know, this is just something people talk about, and it may be very scary to go see a therapist. So what would one expect? And then how would they even know if it's working? You know, some people can go to a therapist for months, and they may not realize really what effect it's supposed to be taking. So this question is directed to Alexander Rand and Dr. Pearlstein. The rest of you are please answer.
What should you expect when you go to therapy? Is to spend a lot of money. It's not cheap. I really recommend that people put away money for their kids and grandkids, like for college, for therapy as well. Okay, we have to live as well, what can I say? Now, what you expect is that competent therapists, and I don't want to say this lightly, have gone through enough training before they're opening up a private practice and just, you know, putting up a shingle and saying, I treat, you know, this, and everything. I'm going to give a little bit of a shout out to the Jewish board because I spent 7 years there. One of my past supervisors is here, Rivka Nissel. She herself put up with me for a few years. That tells you a little bit about her. But working in a mental health clinic for a bunch of years and getting supervised again and again and again gives people a little bit of a background of what it is that you want to do. The initial visit should be an assessment. You can't treat somebody without knowing what you're treating for. Someone comes in and says, hey, I'm depressed. Okay, great, let's talk about how to treat depression. Wait a minute. Many times clients come in, they think they're coming in for one issue, it's really something else. So you have to do a comprehensive assessment. You're asking them about when the problem started, how long it's been going on. Be ready to answer a lot of questions, by the way, and personal questions. This is the only profession you can ask somebody anything you want and not be embarrassed about it on the first visit. So we're going to ask about past history, we're going to ask about family relationships, we're going to ask about what they enjoy, their social life, depression, anxiety, trauma. We're going to cover everything if we're doing it well. Sexuality, religion. These are things that these should be standard questions that are asked when someone's coming in for treatment, of course, catered to the age and appropriateness of each client. So what you should expect initially is an assessment, and a good assessment. Afterwards, you should have a discussion with your therapist about, do you feel they're a good fit? Do they feel you're a good fit for them? What treatment might look like? Meaning, how are you going to help me? There's many, many modalities of treatment, which is another question here. And not every modality works for every client. You know, we'd like to think that this modality works. Yes, it does, for some people in some situations. There's a reason why there are many modalities that are out there. It's good to become educated on different modalities. So you have to tailor what it is that you're giving over to your client for what the client's going to be able to accept and receive, not just where you think you have the greatest amount of knowledge. Treatment itself, you know, parents frequently ask this question, you know, how much money is this going to cost me? That's usually the first question I get. And it's like, how long is this going to be? Like, maybe just fix them or something. So I remember one father was saying to me, he kept asking the questions, listen, I can't really tell you, I haven't met your child yet. He said, listen, just give me a bottom line figure. I said, I don't, just give me a number. I said, okay, $500,000 for your child and you. Package deal. No, I didn't say that I thought that. They teach in therapy school, don't say everything that you're thinking. But we frequently cannot predict initially how long therapy is going to last for, because it's not me setting your arm in place when it's broken, which I don't need, like the doctor mentioned before, taking an antibiotic, which doesn't need your participation in it. It'll happen, it'll work anyway. If the client's willing to work, therapy's going to go quicker. If it's a good match, therapy's going to go quicker. There's less stressors in the client's life, therapy's going to go quicker. If the therapist is better trained, therapy's going to go quicker, but there's a lot of factors. So it's hard for a clinician to answer, give you a time frame, although there are issues that are short-term issues, and there are issues that are long-term issues. I'll give an example of both, and then I'll pass the mic. A short-term issue, for example, is a specific phobia. Somebody that comes in, and I had a client recently, came in, a fear of driving on bridges and tunnels, and he needed to do that in order for his job. That treatment is very specific, and if the client's motivated and willing to do the exposure response prevention and continue with it, they'll get better quickly. This person, I think, was motivated to save money, so he followed all the homework, and it took about 6 weeks. But then there are clients that I've been working with for 2 or 3 years, and it is a long-term issue. And we don't know. It could be years, it could be 2 years, 3 years, 4 years. The client should feel that therapy is working. That's one thing. You should never be in therapy for months and feel like this isn't doing anything for me. This isn't helping. You should feel like you're getting helped. In terms of reaching the goal, what you came in for, again, it's hard to determine.
I was just going to add to that. when someone comes in for therapy, like Dr. said, the initial session is about, questioning. It's also, in addition to the interview, the questions, it's also that the client is trying to see and assess whether this is a therapist that they could work with, and the therapist is doing the same to see if there's a good shidduch going on here. Because if it's not, then it won't work. But, basically the question was, I'm in therapy for about 6 months and nothing is happening. What should I do? I think that anyone who's in therapy, in my professional opinion, if you're in therapy for 6 months and nothing's happening, you have way too much patience. Way. Because things should be happening, not necessarily in the first session where there's the interview process and all these things that have to happen, but certainly within the second or third session. Because what is therapy after all? It's about bringing awareness and insight that will help change the way you think and the way you function. And those kind of changes should be happening definitely slowly, but they should be happening. Even if it's happening slowly, it should be happening within the first few sessions. So if you're in therapy with someone and 6 months, nothing's happening, for sure, it's a sign to look elsewhere.
So a couple of things. First of all, the first couple of sessions are not pleasant, because if it's not hurting, then it's not therapy. Therapy is not supportive counseling. It's very different than that. And it's important to know that going in, that this is not going to be a pleasant process completely. The other point is that if you find that you're in session for a couple of months and it's not working, then I would ask the person I would pose the question, the miracle question that we call it, which is, if things were working and things were better, how would you know? Because sometimes people have this sort of vague idea that they're not happy, but they don't exactly know what needs to take place in order to make that happy, to make them happy, right? So sometimes it's very obvious. So if we're dealing with somebody with panic disorder and they're dealing with fewer panic attacks or specific phobia, right? And now they're able to, because of the exposure, they're able to get to work with the bridges and the tunnels. That's very quantifiable. But when you're dealing with personality concerns, right? And we're talking about, let's say, difficulty sustaining relationships, then it's much harder to gauge progress. The other thing is that therapy is collaborative. It's egalitarian. In other words, if you're concerned that there's a lack of progress, then raise the concern with your therapist, right? Because either you have to modify your expectations, or maybe the therapist can do things that are different. I always encourage my clients to talk about what their experiences are. At the end of every session, I always ask them, how did they find the session, right? So, and the other point is that therapy is work. Walking into the gym is not going to cause you to lose weight, right? So walking into a therapy office, I ask people sometimes, what is it that sometimes you have to be very direct. And the idea is that if you're giving people the skills or the homework, because CBT clinicians always give homework, and they're not completing it, then the question is, then you're presented with a dilemma, which is you want to change, but walking into session is not going to be enough. So there's a lot of work. If you go to therapy, you do have to, expect to work, because we want to generalize it from the 45 minutes in session to the overall, to the rest of your week. But to speak to the last point, which is that if it's not working, then raise the concern with the therapist, and be confrontational about it, because it is a collaborative process.
Very briefly, I had one thing I forgot.
Hold on, there's just a request from the text that the panelists could speak in English. We're translated it into Yiddish, Hebrew, Latin, German, French terms that might come across. Swahili also, please.
I can't, I'm sorry. Therapy, with the pressure of how am I going to afford this in a week or in a month or in a year, there are good clinics that are out there that take insurance, the Jewish Board being one of them. And Rick Benissel's in the back over there, as one of the supervisors. I worked there for 7.5 years. I can attest to that there's oversight, and there are people that are they're checking your cases, there's supervision. So sometimes you can't get to a private practitioner. You can use a clinic, and they can do a good job as well.
I just wanted to add one small thing. The focus tonight is really about depression and anxiety. And most of the types of therapy that we've been speaking about are time-limited therapies. Cognitive behavior therapy follows a script, generally. There are other therapies that you're following a script. Just understand that the answers that you got here tonight about if it's working or not working in 6 months don't necessarily apply to all different types of therapies for all different types of diagnoses or problems. There are some therapies that take years to work, okay? So, and I always encourage people, regardless of the type of therapy, regardless of what the underlying problem is, that they should make a cheshbon ha-therapy, kind of a reassessment of where things are holding every 3 to 6 months. Just to kind of review with the therapist, where are things holding? And back in my days in the hospital, we used to have these treatment plan parties where we used to have to sit around with these huge stacks of paper. It was this, I think, a Medicaid mandate, where we used to have to sit there with our supervisors and basically justify what we were doing. Is it working? Is it not working? What are our goals? That's something when you're working in a brief, especially with one of the brief time limited therapies, that you should be doing with your therapist. The last point I wanted to make is sometimes the greatest work that happens in therapy is when the client or the patient can tell the therapist directly, you know what, I think you're wasting my time. What are we doing here? Why am I not getting better? Sometimes that's really when you get to the bottom of what's going on.
Okay, so we spoke about how mental health really is something which interacts with a person on a number of levels. So the next question is going to Rabbi Grossberg. In terms of Rabbi Grossberg, also in terms of his introduction as the principal of Benochai Academy, which is a very, very special and different type of school. And in terms of that, we'd like to know how a school really can a school and the community surrounding a school can contribute or detract from a person's mental health. Rabbi Grossberg.
So, it's actually an excellent question because the reality is that we're all part of this. And we're all in this together and we all can be part of the solution. The fact that we're here tonight is part of the solution. I think that oftentimes we make the mistake when we talk about a big word like trauma. And we think trauma, we think of abuse, we think of later someone who lost someone or something, other traumatic event in someone's life. Many times I'll speak to a student who is really, really struggling. And when it comes down to it, they were made fun of for the formative years of their life by classmates. And they are just as traumatized. Not that there's a way to quantify trauma, but what I mean to say is that they are damaged to an extent that they've many times, unfortunately, given up completely on the religion because they somehow, they put it all together. I always say God is an easy target because he can't answer back necessarily. But as a community, what we can do is to realize tonight is not the time to discuss the resilience and why perhaps children are not as resilient as they once were. They can't put up with as much as they once did. They're not as strong. I'm going back, it's really doesn't belong here tonight, but I can't hold back with all these mental health professionals sitting here. I remember my day, there was one father who said, my son doesn't need a psychologist, he has 2 psychologists. This one and this one. Somehow or another, many of us, I don't say we all survived, but many of us survived. That's not going on now. Working in having a high school for girls that have been thrown out of school, who are on the street, I can tell you that it's not working. That whatever worked before, if it did work, it's definitely not working now. So if the question is what we can do as a community, is we could try to make every single one of our precious children feel at home. We can be on the lookout for problems. And many times people make the mistake and think that this is for Mahanchim. This is for those that are in education, those that are working. You'd be surprised what, as a neighbor, you can do when you see one of the children. And many people here know the telltale signs. Perhaps a little bit of change in dress, hanging out at home when instead of being in school. There are a lot of things. And you say, me? Well, I'm going to mix into someone else's business? I'm just a neighbor. You'd be surprised as just parents many times simply because they're parents. And I'm one too, so I can't blame all parents. But so they are not going to be listened simply because they're parents. There's too much emotion, there's too much turmoil involved in that relationship. As a neighbor, as a friend, and really in so many different ways, each and every person can help and can see the signs. There are children who have just been forgotten about. Parents are very, very busy. There are many chasnas, many weddings that people are going to. Baruch Hashem, it's great. The community is thriving. If you're looking for a good supper every night, there's a parlor meeting, and nowadays parlor meetings are not just the old cake and seltzer, barbecues and sushi, etc. There's something to do every single night. Parents are very, very busy. But as a community, we need to realize, though, that sometimes children become the sacrifice. And together, if it becomes a community-wide thing, not every parent is capable of dealing with their child's problem. Sometimes parents are dealing with so much shame over what their child is doing that they make bad parental choices. If we can get up to that parent who's suffering and struggling and say, don't worry, we know what you're going through. It must be so difficult for you. And they can start to rest and breathe a little bit easier and feel that they're not being ostracized by the community. They're not being looked at as bad parents. Then they can start to parent better. They can be helped, but really, it's a mistake to think that this is something just for the educators or just for the Rabbanim. Each and every person here can do it and create really a change within the community where we've become more accepting, we've become more welcoming to everyone, and to use the simple words, we need maybe to make the box a little bigger when we're trying to make people fit inside the box.
So, I'm going to answer this a little bit similar to the question about the Rabbanim. Schools are a place designed to educate our children and make them feel safe. When the school principals, administration, and teachers take on the role of psychologists and therapists, instead of recognizing a problem and sending it to somebody appropriately, you are doing a disservice. Unfortunately, in our current system, the schools, by the way, I speak as an expert. There's probably not many people in this room, if anyone, that has as much experience in attending as many schools as I did. So there's nobody here that knows more about education than me. The biggest consultants. The method of our school systems has a lot to be desired. I will give a tremendous credit to Torah Masorah for really working hard on changing that, but we're nowhere near where it should be. The schools have a setting right now where you do something wrong, we throw you out. I guarantee you when you throw that kid out, boy or girl, young or old, you're guaranteeing the next issue coming up. Not very helpful. I'm going to use the example of the show. How many people here are familiar with the Netflix show 13 Reasons Why? Heard about it. How many people here have watched it? How many people here have children whose school sent home letters banning it, making sure you don't let your children watch it? How many people have children in schools that sent home letters saying, since we know your kid's going to watch it anyway, here's some great talking points, how to speak to your child so you can explain to them what is and isn't going on. Okay. That's the problem that we have today with our school systems, and I'm going to say this publicly. We are living in an age where everything is being banned. Everything is prohibition instead of moderation. We're not explaining and we're not educating. If we know that our kids are going to see something and watch something, it is our job as parents and our job as parents to force it on the schools to be a part of that process. Allowing the schools to arbitrarily make these decisions and destroy our next generation's life has to come to an end. And I will say this. Most of our children spend more waking hours in school settings than at home settings. We need the schools to step up to the plate. We need the schools to allow mental health professionals, such as sitting on this panel, into the school to have open conversations with the students, with the teachers. And we need the schools to understand that mental illness is real. And people that suffer from it need help. Not to be further punished, further tortured, or embarrassed by it, but to make sure that they can get the help that they need. Everything begins with prevention and education, and that starts with our school systems.
We're going to end up with the scripted portion of the night, taking away our safety net a little bit with the final question, which really on the panelist, it's question number 11, but we moved it around. And so we're all willingly, unwillingly influenced by millennials. Some of us are millennials. Some of us relate to millennials. So if each panelist who feels comfortable doing so, could you try to please express one message about mental health in 144 characters? It doesn't have to be 144 characters, but one statement, one line. If there's one message that if you feel that you gave that message, that's okay. That's fine. We'll just move on to the next panelist. But if you give us one message to walk away from the scripted part of the panel, before we go without our safety net, and they bring up some of our questions from the floor. The anonymous ones first, and then we'll take some hands, and then move on to the last portion, which will be our research fair.
I guess I'll go first. Okay. So very often mental illness it's a disease of separation where people feel different, isolated, and alone, and you really don't have to be.
That was for all of us, by the way. That covered it all. Mental illness, I will. Mental illness is real. It's something that needs to be addressed and something that we cannot shy away from anymore. Confront it, deal with it, get proper help, and help support these wonderful therapists.
Just want to reiterate what I just want to mention that I have business cards, okay? I brought a lot of them. You want one? One thing, people aren't crazy. Human behavior, every behavior that somebody does, there's a reason behind it. Let's try to understand why before we judge it.
So as a child psychiatrist, I always get a very, very thorough family history. And I always ask the mother for her maiden name. Maiden name. It's not for identity theft purposes. And I always ask afterwards what their family history is. I tell them, both parents, I want you to go up to your grandparents, look at everybody underneath, so multiple generations, hopefully large families, and I want you to tell me what addictions run in the family. I want to know what psychiatric problems run in the family. 99% of the time, nothing. You know why I ask for the mother's maiden name? Because I know more about their family histories than they do themselves. Every one of our families has mental illness. Just like every one of our families has cancer, has diabetes, has hypertension. We can't run away from this. And how do I know? Because it's the same grandparents paying the bill. That's how I know. And lots of times, it helps me to pick the right treatment. I could make huge mistakes because I didn't know that. It's time for us to be open with each other. It's time for us to stop thinking and worrying about the shidduchim of 6-year-olds with ADHD and what's going to be when they turn 18 or 19 or 20. It's time for us to stop running away from the problems. The ostrich approach to life doesn't work. Face the problems.
What I'm about to say now is a little embarrassing for me, but I'm going to be honest. That always gets everyone's attention. So, as I mentioned, that one of the things that I do is as rabbinic advisor for an organization called Chaskenu. Give a plug for it's an amazing organization of peer support where people support each other. Those women that are struggling and female members might have, let's say, male sons or husbands that are struggling. And there's a whole host of phone support groups. And really, it's an amazing organization. And I don't get paid for that. But the first time that I spoke at a Chaskenu event, I have to be honest, I walked in and I was waiting for the people with mental illness to come in. Because I was waiting, maybe it would be obvious. And the room starts filling up, and I said, wow, they have so many people here that are just here to help. When are the people with the mental illness going to come in? And then there's no more seats. I said, this is terrible. All the volunteers took seats. The people with the mental illness are going to come in. There's not even room for them. And the answer is that they look and act and are just like everyone else. There are husbands, wives, children, neighbors, cousins who have this, but they're struggling, but the words mental illness would, and I admit it was an education for me. The words mental illness sometimes conjure up a vision in our minds that is so wrong and just so, and that's where the stigma comes from. That's where the stigma, what we're looking for. People with jobs, with families, with tremendous success. They're perhaps the only difference may be the medication that they take in the morning, or the therapy that they're making sure to go, or having that support group. But it's important, if we want to end the stigma, we have to just, education is what ends the stigma. I got educated that night. We met a most wonderful group of people who clearly are thriving, clearly are strong, and facing challenges that many of us couldn't even dream of, facing those challenges and surviving and thriving with those challenges. It's important that we get a clear picture of what it is so that we stop stigmatizing without really realizing what it's all about.
I'm sure you've all heard the phrase, we don't have a choice about what happens to us. We do have a choice about how we react to what happens to us. So similarly, we don't have a choice about whether we get mental illness or someone we know that we love has it. But we do have a choice about whether we stay in denial or whether we come out of denial and take action and fight it. And I think that that's what tonight was all about. The opportunity to come out of denial and step forward and speak to us and see if there's any way that you could come out of it. Thanks.
Okay, so we'd like to take a couple of questions from the floor, if anyone has questions from the floor. Okay. Let's, okay,
wanted to be a teacher, so
sure.
it's my chance. I'm in a school
yeah.
setting.
You want to test the wireless mic? Sure. It's great range.
Hi, my name is Liba Shajay, and I am training to become a peer counselor. In the state of New York, that means I have a mental health diagnosis. It means I have been an active participant in the, specifically the Orthodox mental health community for about 10 years, and I have been a volunteer. I have been a patient consumer, client, every word under the sun myself, and I am now training in mental health counseling to help others at Howie the Harp. I'm in an internship at Columbia. And my question is, how can we get funding for the specialized therapy that people need when they graduate from the basic clinic therapy? And people realize that they have greater traumas and they need things, because Tikva just shut down their DBT group. Amudim only helps people who have very specific type of abuse in their background. And Evolve shut down a few months ago. And I am have so many friends that are going through their savings, and there is nothing. We do not have a High Lifeline or a Bonei Olam or a PUA for mental health. We need one. We need one now because people are spending their life savings, and I have had 5 therapists who went private on me. They're charging $250 an hour. They made a really good amount of experience on me, and now they're charging. I need to know how we can afford this. Thank you.
As the only one on this panel who runs an organization who relies on public support and donations, I can say thank you for that question. And when you get that answer, when you get that answer, you can let us know. There's a major misconception in the world, and I'm going to say this just so we can all get that straight. Organizations don't run by the mere fact that somebody wakes up one day and poof, there's an office and staff and material. And people in organizations do the best that they can, but realistically speaking, if you're looking for specific funding and it's not out there, I welcome anyone to open up an organization and try to raise the money. To expect an organization that's working as hard as it is to continuously be a bank is not realistic, unfortunately. And I also recommend people to speak to their politicians, who are elected officials, who control hundreds of millions of dollars of state funding, federal funding, and city funding, and ask them to create additional programming. From a purely financial perspective, I will speak on behalf of any organization that works hard to help people. They do the best they can, and people need to learn to appreciate the work the organizations are doing and look at the positive and not be upset that there isn't enough funding, because that's not up to the organizations. That's up to the public who has to support it.
Thank you. Okay, in the back.
Out of curiosity, have any schools thus far expressed interest in planning awareness programs?
Of course, it's got to come from.
Where is Rabbi Winograd? Where are you? Because I think Rabbi Winograd could actually answer that question. I heard the question.
I will tell you that Torah Masorah currently launched 2 new initiatives. One of them called Project Lishmar, another one is partnering with other organizations to start dealing with those issues. There are certainly schools out there that have signed up to various awareness and mental health programming that we know of, and we get calls from schools on a pretty regular basis, at the very least to train some of their staff. But the simple answer to your question is not enough. So I'm going to repeat the question because I like that question, and I'm going to go for it. No, it's a good question. People need to hear it.
She works in my school.
I was going to say, she works with my wife, who works in that school, and thank you for being you. The question was, what are the administrators so scared of? So I'm going to tell you. One of the questions that was posed tonight is, everybody always is open-minded about issues, yet when it comes to shidduchim, which by the way, in my opinion, the dirtiest, nastiest word in the Jewish dictionary today is the word shidduch. Because that is the #1 excuse why people don't do what they need to do. What they're scared of is confronting the reality of what's going on. Unfortunately, that shame and stigma that we keep talking about, that I must again say, thank you to everybody here for coming to helping to break that barrier. And you can give yourselves a round of applause for that. Is what we need to work on as a group and as a people. The school systems are still living in that box, unfortunately, for the most part. No, it's not every school, but a lot of them. And I know this from the clients that we deal with that should have never come to us because they should have had early detection within the school system and had some better programming. But really, those of us that have children in schools and those that are watching, it's upon us to get the schools to make those changes. We have to come in as a parent body and say, we understand this is a real problem and we would like to see the school make those changes. Because if we don't push for it, it ain't going to come on its own. And I'll tell you, everybody said it's impossible to make those changes. So just quick props to my community. I live in Queens and Kew Gardens Hills. The first community as an entire community to bring in sexual abuse awareness programming into schools was all of the Queens elementary schools in conjunction with the Vada Rabbanim of Queens. This was due in part, yes, to a lot of community leaders that put it together, but getting enough parents to say, we want this, we demand it. We, the parents, have a lot more power than we believe, and we need to step up. It's for our children and the next generation. We need to get the schools more involved.
Hi, so Refuat Nefesh is a pretty new organization. It's only about a few months old. Refuat Nefesh. My particular role is in charge of outreach, so basically trying to bring different campaigns pretty much across North America. Do you hear me now? Awesome. So my particular position is trying to bring different outreach campaigns to different communities. We're probably going to segment them by age brackets, so probably one for adolescents, one for young adults, college-aged, and then general adults and beyond. I think our first campaign that we're going to be rolling out in the fall is basically like an essay writing contest, so it's pretty traditional, tried and true. And then I'm also sort of secretly at work in trying to develop more deeper, fundamental, kind of game-changing things to try to tackle stigma at a much more elemental level. So that's probably also going to be rolled out in the next few months. But if you want to get involved, it's a new organization. There's definitely a lot of ways to get involved. We have people across a range of spectrum in terms of religion, professions. Most of us are... What?
What does the organization do?
What does it do? So again, it's pretty new. We're not doing that much yet. A lot of the stuff we're doing is still in the planning stages. What we have started is there is a chat room where people can go into, either people who have a mental health condition, people with a family member, friend, or whatever. They can post questions. So meaning there's places, forums you can ask questions and get answers. And then there's also specific times that there's chats that it's moderated. People can get answers and discuss different issues related to this. There's a lot of social media activity trying to share information that's relevant. And like I said, there's some other things, anything that's mental health. Okay, so any single diagnosis, meaning questions people have will usually be specific to a mental health disorder, and the forums on the website are divided usually by the specific diagnosis. But in terms of stigma, it's pretty broad. I don't have a strong reason to believe that stigma differs by the disorder. And so in terms of the stigma piece, we're really focused on every mental health thing across the spectrum.
Thank you. Okay, our last question, and then we'll be reorganizing the room. We have a question up in the front, actually. Was with regards to, if you want to ask it more clearly yourself, but what happens when you have a child who, a minor, I'm assuming, who really does not want to go for therapy, but you really see that there's a need? Anybody? Force anybody to know. Right, yeah, absolutely.
The whole audience is going to do it too. Yeah, everyone's listening to me. It's Mother's Day. My mother and my sister are here.
Oh,
She knows.
I mean, okay, it's very hard to help someone who doesn't want to be helped. So what I do when I work with kids that are resistant is sort of try to collaborate with them and create this, I'm trying to think of another word, but a collaboration where, okay, what will it take for you to convince your parents that you don't have to come back? And that's how you usually draw people in. But I can say that working with kids, you need to work with the parents. And that's the barrier very often, where parents very often, they think that, here's my kid, fix him, and I'll be back in 45 minutes, and that isn't the case.
Can you answer that?
So it depends. Okay, it depends what the underlying problem is. If we're dealing with a little kid that has behavioral difficulties, there are certain types of therapy that can be effective even if they're not willing participants. Once we're dealing with adolescents, though, It depends on the problem. You know, if we have a teenager that has a substance abuse problem, then we're going to drag them kicking and screaming, even if they don't want to go. Huh?
It's not that. It's not.
What kind of problem are you?
Defiant problem.
Depending on the age of the child and whatever else is going on, there are some therapies that can be effective even if they don't want to participate. But sometimes, quite honestly, you have to be really, really smart about choosing the right time to make the intervention. Sometimes it's better to just work on building the relationship with the child and just having you consult with a therapist on how to do that and try to help them from the side a little bit in the meantime until they're ready to go and get help themselves. But also, lots of times, defiance is part of something else, and it really needs to be identified. What is it? Why is this child defiant? Is it just a normal part of their development? Is it part of ADHD? Is it something else that's going on? Because the way to deal with it will vary, and some things don't need to be treated. Sometimes people mature, and they get better with time.
I think it's a very, very relevant question, and it comes up a lot, especially with addiction, when people don't really want to get help. With adolescents, what I found is that there's a stigma, I think, on therapists, which is terrible, it's unfair, and we got to break that stigma that we're not cool. We are cool people. And I tell the parents, get me the child in once, and let me see if, like, my sense of humor and showing them that I'm cool will get them to continue. But all kidding aside, actually, you should know, I think my most proud moment was when there was a young man from a local school said to me, "Do you want to come hang out with my friend? We're going to the club tonight." I'm like, "You don't want me going to the club, trust me. Like, I'm good in this office, I'm not good in the club." But I think the therapist's job sometimes is to connect to that child during that first session, you know, to try to connect, find something that they can speak about, sports, to start the relationship and break that stigma of, you're crazy, that's why you're here, you're weird, and, you know, etc.
Thank you very much. We are now going to move to the next, the final portion of our program for the night. All of our panel will be around to ask questions too, especially the more specific questions that were asked, really, but which are great, just not for the public forum, so you can come and speak to any of our panel members. We also want to present to you,